thank you everyone for coming to this panel. It's our second panel of day 2, and we're going to be talking about long-term relationships and all of the work that has gone into forming those long-term relationships within the field of global surgery. We're really excited to have with us some partner pairs and also folks that have been involved in the global surgery field for a very long time. And so looking forward to hearing about their wisdom and experience that they've gained from it. I'm extremely excited to introduce you to your 2 co-moderators, Kara Faktor, who is a current 4th-year medical student at UCLA, and Daley, who is a 2nd-year medical student at Howard. Just before we get started, I did want to say that unfortunately we had asked 2 other panelists to join us today. They won't be able to make it due to other reasons, especially due to COVID. So Dr. Sabrina Asturias and Dr. Sergalen Orgoy, but just wanted to acknowledge their presence otherwise here on the panel. And so I'm going to pass it over onto Kara and Belaine.
Thank you. So thank you everyone for joining us today. We are very excited to welcome this wonderful group of very experienced panelists so that they can discuss the lessons they've learned from their global partnerships that they've been involved in. And our first panelists that we're going to introduce are Dr. Mark Newton, who is a professor of anesthesia and pediatrics at Vanderbilt University Medical Center and director of the Kenya Registered Nurse Anesthesia at Kijabi Hospital, a rural referral hospital in Kenya. He's also the director of Vanderbilt International Anesthesia, where he facilitates exposure of anesthesia residents and staff to global anesthesia, as well as research project development. Dr. Newton has been involved for over 20 years in anesthesia development in East Africa, where he lives full-time with his wife, Sue, and their 5 children. He has focused on providing safe anesthesia capacity building through education for nurses and physicians in Kenya, South Sudan, Somalia, Ethiopia, in partnership with ministries of health and non-governmental education institutions. He has developed a training program approved by the government of Kenya to train nurses at Kijabi Hospital for the rural anesthesia care of Kenya. And he is a faculty member of the University of Nairobi, where he is involved in physician anesthesia training, continuing medical education, and national anesthesia development programs with the Kenyan Physician Anesthesia Leadership. And then I would also like to introduce his colleague, Dr. Peter Nthumba, who is a consultant plastic reconstructive and hand surgeon at Kijabi Hospital. And after graduating from the University of Nairobi Medical School, he trained in hand surgery and reconstructive microsurgery in India and Spain, including work in a hand transplant unit. He then returned to Kijabi Hospital, where he developed the plastic reconstructive and hand surgery unit there. Dr. Nthumba served as the medical education and research director at Kijabi Hospital until 2015, and he is a fellow of the College of Surgeons of East Central and Southern Africa, as well as a clinical associate professor in the Department of Plastic Surgery at Vanderbilt University Medical Center. He is a past president of the Surgical Society of Kenya, and Dr. Nthumba has a deep interest in patient safety in surgical infections and was a member of the WHO guidelines development groups that developed the hand hygiene guidelines published in 2009 and the Global Surgical Site Infection Prevention Guidelines published in 2016. He is the coordinator of the Surgical Unit Safety Program at Kijabi Hospital, and he recently earned his MSc in Epidemiology from the London School of Hygiene and Tropical Medicine. So welcome to our first 2 panelists.
Well, thank you very much. I'm going to go ahead and share my screen. And so Peter and I can start talking. Just thank you for this opportunity to talk. Peter and I are good friends. He's a neighbor. He's operated on about all of my children, or at least 3 of them, and even myself. So it's good to be here. We only have a short period of time, so I'm just going to jump right into it. That's a picture of where we both work. Our houses are kind of right over there. So this is Kijabi Hospital. It's a rural hospital in Kenya, about 50 kilometers from Nairobi. It's a national, one of the top national, not the very top national referral hospital, but in the scheme of referral hospitals, it's a very large hospital. So today we really want to help you understand partnerships, and to do that we're going to have some objectives, and one of them is just to understand the importance of the bidirectional part of partnerships. The second part is this whole idea of institutionalizing the relationships. We want to just make sure everybody understands that it shouldn't be a one-man show or a one-woman show. It should be within the institution. So we'll talk a little bit about that. So just understand the two different high and low resource type settings. They have different pushes and pulls. And so anybody working in another country or even in this country, really communication, the culture of medicine in those countries needs to be somewhat understood. And then technology, certainly technology is very different in each part of the world, and the infrastructure. So understanding the differences between that technology and infrastructure is super important. And then just oftentimes from the high resource setting, you know, we have this whole idea of research, and there's this whole research burden. And then this other big pull on the other side is the whole disease burden. So sometimes this conflict between research and disease comes into play when we have different infrastructures and technology and things like that. So it's something that you always have to remember when you're involved in partnerships. So what's going on from the high resource institution? Many people on this call are from these high resource institutions, and I'm sitting in one now. People are focused on their career, they're remote, they're concerned about rotation. So the experience of their trainees, safety, health, malpractice, visas, their perspective is short term, usually days and weeks, maybe a month. They're always asking about where the funds are. They have this massive administration support system. And really, they always have to look and see what their initiative is. If it's for the individual, are they based on this, on their high income country institution? Is it foundational? Is it government? Who's driving this relationship? And on the other side, it's certainly driven by patient care. Every physician, nurse, healthcare provider in a low income country is totally pulled into the patient care aspect. They're more interested in building human resources and infrastructure. Their perspective is longer. It's in years and decades. It's really not when are you going to go home, but when are you going to come and stay for a year or two or three or a decade. They have limited funds. Research is important, but it's just not at the top. Administrative and accounting support is not there most of the time. There's issues of licensing, IRBs. So when you come into a country, you have to have a license. And then the institutional goals. What are the institutional and national goals of the country? The country could have a plan for surgery and anesthesia, critical care. You need to know what those plans are. So one of the questions that was asked us was specifically about the development of this partnership. And so Peter and I discussed, and really what is that, how is that formed? And each partnership that comes into play typically is started by one person from one side or the other, and then an institution. And really it's probably individual to individual. But for the Kajabi, this is a hospital that's 105 years old. There's been many people traveling there, but specifically related to the Vanderbilt side of it. I've been there for now about 12 years from Vanderbilt. I've been in Kajabi for about 23 years. Prior to that, I was at Denver Children's Hospital. But really, it's been developed over the last 8 to 10 years, and it's not as coordinated as people would like to think. I feel that the vast majority of times that there's not alignment of high and low income institutions. And certainly the anesthesia side is a little bit different than the surgery side. But, and Dr. Nthumba will talk about this in a minute. But this whole balance between tech and touch, I mean, we feel that we need to do high tech because we're remote. But actually the more important part is the high touch part, where you're actually in play in these countries. And the way I like to look at it is that sometimes you hear people coming back from Southeast Asia or Africa, and it's like they're rushing around trying to put out a fire, they're coming in and they're leaving. That's kind of the remote type setting. The other side is trying to build bridges, trying to build infrastructure. And so we have to try to come to some sort of balance between the two. And certainly not everybody's going to be able to move to a country, and everybody's not going to be there for building the bridges and things like that. But in a sense of trying to balance the two, we have to look at both of those and see how we're going to have a balance. So I'm going to turn it over now to Peter to talk about two other questions that were posed to us. So Peter.
Thank you. If I can find, I hope I'm able to stay on video for long enough. Sometimes things go down. So Mark has covered most of what where we started, at least specifically with Vanderbilt. Out of this, there are a few other institutions that we've sort of moved along with, created MOUs. I'd like to recognize my mentor and friend, Louis Carter, who really introduced me to a lot of the contacts I've had in the US, and then that's moved on some relationships. I think it's important to note that the relationships start at a friendship level usually. So the two individuals from the two different institutions will come together, recognize some needs, and move on. The problem I think we discussed briefly with Mark is that frequently the partners from the high income country have very specific goals. The good way to look at it is they're going to be spending money, and they need to give to account for that money. So they've got specific goals, they've got specific plans. When you come to the LMIC, I frequently say that global surgery, global health is still not well defined in terms of definition. High-income countries understand global surgery. We don't quite get it in terms of that definition. And so when it comes to goal setting, it's still an issue, very fluid, because when you come together, the high income country partner has specific goals, and they've got, part of it is the biggest resource is actually money. The low income country biggest resource is resource, patients, opportunities, infrastructure. And how do these two come together, and how can the two groups gain the best out of that relationship? So at the beginning, I could, frankly say, I don't think we as an institution understood exactly what was in store for us. I, on the other hand, believe that Vanderbilt had it fairly well figured out. As we've moved along, our relationships have improved in terms of, as we both have looked back and looked at what have we done, what have we not done. For example, Vanderbilt did get to the point of, okay, we see the benefits of this. How can Kijabe benefit? And some of those things have been individual. Like I've had the privilege of becoming, I'm a faculty at the Department of Plastic Surgery, very good friends up there, especially with the chair currently. I've also had the opportunity to visit and speak a few times at Vanderbilt, as have some of our faculty, but we'd like to see that move a little more. The other bits are certainly the networking that comes up with residents, and opportunities for them to collaborate. What did you like or dislike about this process? I think one of the things that perhaps most of us should think about is the fact that when you're setting up a relationship, it's important to, from the outset, figure out what are your goals, what are your objectives, where are you going, what are your obligations. Are you able to, at some point, sit down, audit the process every year, every 2 years, and so that you make sure things are moving along. Funding is difficult to discuss because I've already alluded to that, because money is a one-way stream. And then how do you balance the availability of money from, so to speak, from the high-income country institution and what LMIC has to give, and how do you balance that? I think somewhere else you talk about equity, and so power dynamics generally are defined by access to finance. Equity is easier to discuss. How can you make the relationship equitable? I think those are important things to put down on the table before things start. Research is a much easier one to deal with. However, it's very easy for a high-income country to come into an institution like ours. We've got a lot of data that we've not made very good use of. Someone else will come. They've got training. They'll grab it and take it away. So part of the process would be, how can we how can the LMIC collaborators be enriched, empowered to use whatever data they have, because data is powerful. That's what pushes advocacy and improves patient outcomes, etc. And so collaborations are important. Collaborations and partnerships should be looked at as bidirectional, in the sense that right from the beginning, even without having the same weight in terms of what you think you're bringing to the table, I think it's extremely important for both partners to critically look at what they want to establish, where they want to go, or what they want to reap, and like I said, be able to audit it and see that that they are going somewhere. And I think that's the important line that we've got down there. Sustainability. You cannot really talk about sustainability when you don't have a plan. And my proposal would be consider every opportunity to interact with an LMIC partner, a project, and then develop goals from that project, whether that's short-term, long-term, in the medium time. I think the rest, see the okay, I guess, yeah, this is an important question. What should students and trainees know about forming partnerships? I think especially the US in the current setting, social setting, I don't know how long it will take to re-examine stuff out there, but I think the courage to accept past mistakes, the willingness to delve into ensuring that they do not occur under our own watch. Like I think I pointed out, accept that while iniquity will always be present, equality does not require resources. So respect for one another. I think it's important. Ethics are important at all time points of such a relationship. Part of ethics, I think, is figuring out what this culture says, what this culture does. I mean, fortunately, you can't throw stones at me from the US, but I think the US culture has a big focus and stress on me. I'm a very important person. We're moving there, unfortunately, but we have a big focus on community. And so understanding what that means is important if you're going to be able to work well with a partner. Understand what their culture is, where they come from. And then again, I think measure outcomes and report them honestly and visibly. I mean, the history, talking about history of global surgery, is we short-term trips, whatever you call them, have a lot of poor outcomes, very poorly audited, very poorly reported, a lot of money used, a lot of wastage of resources. I mean, you're going to come and do 20 surgeries in 2 weeks, but you're going to bring in 20 people to do that. We already have the personnel. We could use that money for a year. I mean, a good example is I'm running a surgical unit patient safety program now for 13, 14 years. I was given seed money for the project through the WHO. I still use the same money to run to collect data, and I've been doing that for 14 years with money that was supposed to have been finished 10 years ago. And but if we had people coming from Geneva every quarter to collect that data, that would have lasted 2 years. So I think those are important. So get to know, create relationships, create trust in those relationships, empower, and then collaborate and honor, respect one another, I guess. And then be transparent with what you're doing and your outcomes. I don't know what a time. All right, Mark, you wanna?
Yeah, let me just, thank you, Peter. Let me just kind of a couple summary slides that partnerships can have a huge impact on a continent. This is the anesthesia impact from Kajabi. That's the surgery impact. Peter's been certainly involved in this. These are all countries where trainees have come and been trained in various areas of surgery, pediatric surgery, orthopedic surgery. Huge impact for developing partnerships. And Peter and I would both agree to this, is that it's very difficult. The things we're talking about takes years. And certainly we can learn from the marathoners in Kenya and Ethiopia, but just a couple of things. Start off slow. When it really hurts, don't expect it to be easy. It's super hard. This whole thing about bringing all your own energy bars, I've read some things about the Kenyan runners. They basically don't rely on all this fancy stuff from runners in the States. They eat local food. We don't need to bring in thousands of boxes of supplies from the United States that we only use and then take it home with us. We need to be appropriate and never do it alone. Never think that you're going to come into a country and you're going to solve all the problems in 2 weeks. It takes years and years and years to do this, and you need to get somebody who knows the road. And the people who know the road are the ones who are living in Kenya and Ethiopia and Tanzania. So these are kind of the rules for academic partnerships. So we'll stop there. That's our last slide. I'll stop sharing and we'll let someone else talk. Thank you.
Thank you so much, Dr. Nthumba and Dr. Newton, for sharing your insight and just giving us advice on how to form and craft sustainable partnerships. Next up on our panel, we want to invite Dr. Jayaraman to speak. She's a professor of surgery in the Division of General Surgery, the director of the Center for Global Surgery, and director of research at the Center for Medical Innovation at the University of Utah. She completed her general surgery residency at UCSF and received her master's degree in public health in developing countries at the London School of Hygiene and Tropical Medicine and Trauma. After her residency, she went on to complete her critical care and acute care surgery fellowship at the Brigham and Women's Hospital and Harvard Med School, where she was awarded the Harvard Medical School Health Disparities Fellowship to work on evaluating disparities in injury mortality in Kigali, Rwanda. She's worked on several projects on trauma epidemiology and trauma systems development in Uganda. She's authored numerous publications on injury in low and middle income countries. And currently her main partnership is with colleagues at the University of Rwanda and the University Teaching Hospital in Kigali. We also want to invite a second panelist, Mr. Jean-Marie Uwitonze, who was trained in Rwanda in anesthesiology and critical care before pursuing graduate studies in international public and health management at the University of New South Wales in Sydney. He's had over 15 years of experience in clinical and managerial positions in various health settings. Currently, he's the pre-hospital team lead at the Division of EMS in the Ministry of Health Rwanda and the head of the National Rapid Response Team in the Joint Task Force at the National Command Post for COVID-19. His research interests include epidemiology, data science, infectious diseases control in emergency and disaster situations, and governance focusing on quality improvement processes. We want to invite both speakers now. Thank you.
I'll sort of set the stage and then Jean-Marie can take it forward. Is that okay with you, Jean-Marie?
That's fine, thank you.
Okay, nice to see you. Thank you for the introduction. What I want to say is, how our relationship started and where it has gone from there. And Jean-Marie can hopefully counter and tell us about how the relationship looked from his perspective. I have no specific ties to Rwanda, but when I was applying for my trauma and critical care fellowship, my good colleague and friend, Robert Rubiello, is at the Brigham and said, hey, through Partners in Health, there's a major collaboration in Rwanda. We're starting to think about surgery and trauma. Would you like to be involved in that? And you can come here for fellowship and we can get involved there because there are a lot of colleagues who are interested, especially in trauma. And I was absolutely excited to be involved. And so it led to several, conference calls and meetings and in-person meetings with first just an attempt of saying, well, who are all the different people who are interested in trauma and surgery at the main institutions in Rwanda, and who are other partners? There are always other partners who are involved who you just don't know about. And we thought, well, let's try to be coordinated and complement and supplement other partnerships so that we're not reinventing the wheel. We're not using our resources in an inefficient manner. So that was some of the first conversations. And so back about 10 years ago now, we had some sit-down meetings with the dean of the medical school, various heads of hospitals, and all of us together, the head of the pre-hospital team, to say, okay, well, great, trauma is an important issue that clearly everyone is mobilized to think about, but do we have any numbers? Do we have any information about what is happening to trauma patients where? And so we started out sort of asking those fundamental questions and thinking about what the system looks like and how do we start evaluating it. And we really had the perspective of, this is not about surgery or surgeons, this is about systems of trauma care. And wanting to ask questions about, well, how does the system provide or allow the delivery of trauma care? And so we ended up doing projects related to pre-hospital care, trauma care at the hospital. And then we developed a set of sort of ideas around what are current strengths, what do we need to do in the future related to clinical capacity, related to research and QI capacity, related to leadership capacity. And then we presented that at the Ministry of Health, again, in a collaborative manner, to say, hey, here's the picture of where we are and where we'd like to go. And that led to a memorandum of understanding between I moved from the Brigham to Virginia Commonwealth University, and that was a memorandum of understanding between VCU and the Ministry of Health to say, here's what we aim to partner together to work on for trauma systems development, looking at pre-hospital care, looking at in-hospital care, looking at quality of care, looking at communication systems. And then we're going to strategize securing funding. What's the process of using that funding and contributing that through the appropriate way into the government and into the institutions that we're partnering with. And that led to more things, more projects related to training for pre-hospital staff, related to standardization of quality of care. And on top of that, again, we wanted to kind of break it up into clinical care and education, quality improvement research, and leadership. So we had funding for people to come to have an exchange. So we had a number of leaders across pre-hospital surgery, nursing, hospital-based staff coming to the US to look at our system. And we had a bunch of support for people there, nurses, anesthetists, to do advanced degrees, master's degrees in public health and epidemiology in whatever fields they felt relevant. And we also worked on other things like setting up the WHO trauma registry across multiple institutions to be able to start to look at quality of care. And we're now at the point where we've expanded to even have even broader perspective to say, okay, well, how do we coordinate all these different institutions and different priorities so that the system can, again, more efficiently deliver high quality trauma care? And so we've looked at, or actually applied for several different grants to do lots of innovative things, including creating a software application that would help more efficiently coordinate the system, as well as thinking about, well, how do we grow the hospital-based staff? How do we bring in the appropriate mentorship for people graduating so that they can take their skills and apply it to pediatric trauma or burn trauma or adult trauma and across specialties? How do we build on a QI program? We're in the process of developing a grant to bring a QI program that my colleagues here at the University of Utah have worked with our colleagues in Ghana on. And so we're hoping that there's some South-South partnership that will occur from that, and that we can apply those QI curricula to trauma and use the WHO registry so that the hospitals across the country that use it right now can really perform QI and benefit from that. So those are that's how my path has been. It's been convoluted. It has not specifically had to do with surgery, although I've been licensed there and I've certainly done rounds and cases. That's not what they necessarily need from a collaboration. It's got to be a much bigger picture. So that's my perspective. Jean-Marie, I'll turn it over to you.
Thank you very much. I think you nailed it well, and I just touched a few points. I have just to remind that the pre-hospital care in Rwanda, when we meet Dr. Sudha, was quite, it was like a baby running to crawl. And having a partner from a country where EMS was so developed was record-breaking for Rwanda. So for us who were just like pioneer in the system, healthcare system, it was somehow challenging. How do we envision EMS in the whole system? How do we coordinate with the hospitals? How do we attract medical student, nursing student to come in the pre-hospital? And how to meet the international standard. So when we met with the Dr. Sudha, we set some key principles so that we can gain or run from the experience, but also try to build something sustainable. And the first principle was to base our works or our activities on evidence or the science. What is going on in the US maybe can be applicable to Rwanda, but how about the context? Because we knew that the EMS or trauma system in US was and still robust, and how can we apply this in our context? Then we set another principle of saying maybe if we have this project, how can it be sustainable to ensure that we're not having a partner who is coming and the next day the project that was built is just collapsing? How can we build something that is very strong and sustainable? Another principle was to base our work on people, so that it's not only practitioners, professionals, but how the impact will be felt at a community level, not only at the ministry or hospital level, but what will be the impact in the community. But also take into account some other challenges, like any other country in around the middle income countries. After discussing these all points, we come out with these ideas of having a project that will not necessarily focus on EMS, but also look at community, pre-hospital, and ministry at policy level. So whatever we do, backed by the science, is coming not only a top-down approach, but also bottom-up, so that whatever we are observing in the community is influencing the way we envision the strategies. So this is how we discussed and came up with these ideas that Dr. Sudha has mentioned. Across all levels. In the policy level, we were able to send colleagues in the US to observe, to learn, and come back and see how skills and knowledge acquired in the US can be applicable in Rwanda. On the clinical side, as she mentioned, we're able to train not only doctors, but also nurses and other allied health staff. But most importantly, for sustainability of our project, we knew that there are fancy or had courses for our staff to learn, For instance, if somebody wants to do advanced cardiac life support, it's expensive, but how can we apply the science in the Rwandan context? We came up with an idea to have the faculty from the US sit down with our colleagues in Rwanda and develop a module that is not only based on best available science, but also look at what is in Rwanda. And we even go beyond the trauma system, go what is needed in internal medicine, infectious disease, pediatric, urban gyne, and develop modules that will respond to the question that we have in the community, but also where staff can have the accessibility whenever they want, and in a sustainable way, and start to generate funds so that the project can fund itself without relying to external funding, but also see how, as she mentioned, we can even share experience with our colleagues in the neighboring countries or in South-South approach. And we achieved this, even though the road is still long, but we were able to train staff that are helping to scale up the project at the community level and the health center where there is a need. And we reached at the level when we are having even visitors from some African countries come and to run and to share and keep learning on this. So the partnership, I think, was very beneficial for both of us because we were able to have medical students from the US come to see about public health project and able to practice their medical skills in the hospital, run, and also we're able to send colleagues go and run and come back. I think the partnership for us was and still a journey that we are walking. And as Dr. Sudha mentioned, we have ambitions, not only on this project that we have achieved, but also to reach at the level that we can not only look at the partnership between the US and Rwanda, but also envision how what we have achieved can be shared to other African countries in order to build the capacity in our countries. Thank you very much.
Thank you very much to both of you. It was great to get both perspectives on how you guys have developed this long-term partnership. I would like to introduce our next panelist, Dr. Juan Puyana, who is the Director of Global Health and Surgery at Pitt and is a trauma acute care surgeon and a global health educator in the areas of trauma, injury, and medical informatics in trauma and emergency surgery. He has been the principal investigator of several global health research and training grant programs on capacity building, medical informatics, and e-health. Dr. Puyana is an expert in developing international capacity building programs in the fields of trauma, trauma registries, and trauma datasets in global surgery. He has established fruitful and reciprocal mentoring collaborations in clinical areas and research educational endeavors with several universities and trauma centers from Latin America and Kenya. He was the president of the Pan American Trauma Society in 2011 to 2012, and working through this organization, Dr. Puyana created and sustained fruitful academic exchanges among many countries in Latin America. He designed several trauma training courses and developed a handbook and course on ultrasound applications for emergency care and trauma management, as well as a course on disaster response. So we'd like to welcome Dr. Puyana to give his remarks.
That's enough. Thank you very much. Too much talk about myself. The reason I'm here is because I was invited to show our experiences in a partnership with Dr. Sabrina Asturias, who is a trauma surgeon from Guatemala. She cannot be here, so I'm going to try to share with you her perspective. It's going to be challenging because I am not her. On the other hand, Sabrina is the person with whom I have been able to collaborate for several years in Guatemala, and I think I have got to know at least her context very well. Sabrina cannot be here today because she was asked to participate in a massive COVID vaccination campaign, and she excused herself for her absence at this meeting. I want to use very little time. I was told there was only about 7 minutes for this presentation. I'll probably end up using less. And instead of sharing with you these big pictures that you heard from the last two groups of panelists from Kenya and from Rwanda, I'm going to go down into a really specific issue that has to do with data collection in places where there is no infrastructure for that. And the reason I will talk about that is because Sabrina has been instrumental in creating a trauma data set for the two hospitals that are sort of the main referral hospitals in Guatemala. It all started because of the Pan American Trauma Society. Through that organization, I always have people coming to Pittsburgh to visit our center. And we have this long list of observerships that like to see how our helicopter system works, our trauma system works. We have a really mature and effective trauma network in Western Pennsylvania. Sabrina was one of those students, came to me as a resident many years ago. And while she was here in Pittsburgh, I had a chance to talk to her about trauma in Guatemala. It's a very different context of global surgery in general. It is a different context on LMIC relationships. It is the ability to sit down, have a cup of coffee, and understand everybody's problem. The incidence of injury in Central America is one of the highest in the world. Honduras, El Salvador, Guatemala right now are the victims of tremendous gang-related violence and domestic violence. And most of that is the result of the war on drugs and some of the international policies and some of the American policies on drug trade. Global health is always more than just our interest to create these partnerships. It's our ability to understand how these environmental issues and all these global aspects of our societies actually have such an incredible impact. What we're seeing today in the border in Mexico and the United States, it is in part the result of failed policies over the years. And Sabrina is the person who has been able to show what is the price, what is the impact that some of these things have in their country. Sabrina's slide, when she goes to the NIH to talk about her projects there, because she has been fortunate to be the PI of two grants to develop trauma registries in Guatemala, is trauma is chaos in Guatemala. Sabrina and I have been there at 2 o'clock in the morning seeing people die because there is no blood products, because there is no enough operating rooms, because patients take 3 or 4 hours to get to the trauma bay. So it's overwhelming. Just to share some of the tribulations that Sabrina has to face with, when she started the first trauma registry in Guatemala, they put a bomb in the hospital and 3 of the nurses died. And that was because the gang-related violence saw the opportunity to kill one of their gang enemies who had been admitted as a trauma patient to the hospital. When COVID took place, she sent me a little text on WhatsApp and said, do you mind if we slow down the trauma collection system? We have no PPEs. Can you imagine the priorities? He said, of course. So even though when you get the funding, even though when you're successful in understanding the problem, even though when you sort of find the common goal, there is always a new obstacle that comes in front of you. And I am extremely pleased and I am privileged to be a friend and a collaborator of Sabrina. I am sorry she's not here. Sabrina went on to give a TED talk about the importance of collecting data for trauma and how that actually could impact some of the health policies through the Minister of Health. And she was also asked to give a little video of her accomplishments because the trauma registry is now working with difficulties, but now she has PPEs for his trauma registrar so they can actually be there collecting data, and has created a sustainable way of supporting some of these data collectors. The registers are new, and we're starting to understand some of the epidemiology of injuries in Guatemala City. And guess what? Violence is not the first killer. Motorcycles and lack of helmets is probably the greatest injury burden in Guatemala right now. Anyway, I'm going to stop right here. I'd rather you have questions. This is very brief. I try to represent Sabrina's struggles and tribulations during her time as a global trauma surgeon, and my ability to be there with her in supporting some of these efforts that are so important in this region in these countries, in this region of our America. Thank you very much.
Thank you. Thank you, Dr. Puyana, and thank you for sharing Dr. Orias's perspectives and her insights. And really generally, thank you to all our panelists for their reflections. It's very rare that we have the opportunity to get this sort of firsthand perspective of what's going on bilaterally in a partnership. And so at this point, we do want to open our chat for questions. And while we're waiting on that to get started, we have a question we'd like to pose to our panelists, and whoever feels comfortable answering can go ahead and answer. And I think it was Dr. Nthumba who mentioned the sort of lack of or waste of resources it involves when we do this sort of fly in, fly out method of surgery. And based on that, we would like to ask the panelists, how did your partnership specifically address the ethical issues that sometimes arise with global health work? Specifically, what practices and approaches did you take as surgical providers from high income countries in an attempt to avoid exerting your own cultural influences into another healthcare system?
Well, it's a hard question. So none of us, I think, are jumping to answer it because I don't know that anybody has good ways to answer it. I think the ethics component is so important, and the blinders that we have on for our own environments, whatever environments we're coming from, are so real, and you don't realize it until you go somewhere else and see the most basic things approached from a different perspective. There's not a great way that in our collaboration that we've specifically addressed ethics or deliberately. I think what we have tried to do is to be open-minded and humble and reflect that in all of our performance and all of our functions as a role model, especially for more junior members of our teams. But I don't know. I don't know if I have a better answer than that. I'll turn to Jean-Marie to see if he has any advice.
I think, as you are saying, it's a matter of having an open mind and be curious what is being done elsewhere, but also in a public health perspective, take into account the different factors that could influence the health sector, the practice, the improvement. It's all about open up to new partners and see what you can learn. It's not so easy because there's a bureaucracy where you have to go through. Dr. Sudha mentioned about MOUs, and some of these in some part of the world, they are very complicated to reach. But whenever you reach at that level, is just to, as she said, to be humble and to run, because you may think that your system is functioning well until you go somewhere else and see something different. And it's an eye-opener for low and middle income country, but also for developed countries, because through this exchange, we are seeing a tremendous improvement on the way people understand not only the medicine, but also the health in general. So the partnership that started from individuals that can go up to institution, there is a way to influence even the policymakers to change the way we used to see this in a good way, but it's not easy. So as he's saying, it's a hard question, but through our experience, we have seen something hard that have changed something that we are seeing is becoming realistic in a positive way. And we would welcome anyone who want to partner with colleagues in these countries. It's hard, but it's possible.
Thank you so much. Sorry. Go ahead, Dr. Nthumba.
No, I was just going to say real quickly, for us, I think because we have had years of collaborations now, not so much with academic institutions as with mission organizations. So our institution, our hospital is a faith-based organization. And so we've had years of experience with visitors. And so through that, we were able to develop tools that define or rather explain to a visitor what our culture is. And then Vanderbilt has its own culture. And what we did was put this into words in developing the MOU. So it was clear when someone was coming from Vanderbilt, what environment they were coming to, and what was expected of them and what was not acceptable. And then the other bit is when, for example, again, from our own experience, if I get a visitor, someone coming to help with plastic surgery here, I'll be around, I'll be their mentor, I'll take care of them. So if they fall into any traps or holes, it really is my responsibility. And that's helped us move smoothly. So we haven't had any ethical issues, but that's because the residents are prepared very well. Maggie and John Tapley lived for very many years in Nigeria, and so they are well versed. In fact, right now they're in Botswana. So John Tapley was in charge of. He was the director of surgery residency at Vanderbilt, and so in developing this relationship, it was very clear for him what culture he would be sending his students and his staff into. And yeah, and then it's easy for me to visit there because visit with them because again, I have an understanding of what I don't know how to define your culture, but what that culture is. So yeah, I think that's kept relationships smooth. I don't think we've ever had issues with visitors because of that. The other bit is, for example, when Dr. Newton is here, if anything should arise with patient care, with attitude, etc., and because I do not have rapport with a given resident, for example, should that arise, it's very easy for me to call Dr. Newton and say, you know, this trainee A, B, C, D, and it becomes very easy for that to be addressed. So that's the MOU, the kind of people that we've had from both sides has made life easy. And with regards to research, again, this is an area that has, I think, a lot of ethical questions where high-income country academic institutions will come, and the right word to use is steal data and publish it and own it. What we've done with Vanderbilt largely is co-share, co-own date. And if you looked up, for example, my name, you'll find quite a number of papers where we have authors both from here and from Vanderbilt. So it's a shared responsibility. I think we've tried to do our best with, although we've never had a frank talk about what's the ethics of this. But I don't know. I guess we've just behaved like good neighbors. Mark, I don't know what you would say.
Just one quick thing. We did develop a prime workshop. So any trainee that's going to Kenya or Ethiopia has to go through this 8-hour session with simulation and be exposed to a lot of these issues. And everyone who goes is underneath a chairman of a department or division that's Kenyan. So they really come in under a Kenyan leadership. And then if there's any issues, they would talk to myself or whomever else is from Vanderbilt that's based in Kenya. So I'll just stop there.
Thank you to all of you. We have another question that came in. And this question says, Dr. Puyana, you mentioned resource allocation. What are some ways providers may engage in advocating collaboratively together and with academic medical institutions, partners, and programs to improve gaining access to specific needs and improving supply chain systems?
I think I'm going to need a PhD in economics to answer that question. I don't know the answer to that. I think the economical challenges are at the root of everything that we see. And you have to go by baby steps. The only way that we in our group in Guatemala were able to make the registry sustainable was to convince some of the politicians that it was important for us to know what was happening to all these patients. And that may or may not last for a long time. If one of the ministries changed the policies, we may not be able to sustain it. And when the director of the hospital has only one position to fill, he's going to hire an X-ray tech or a nurse before he hires someone to collect data. So the needs, the economics behind these are extremely challenging. We have been fortunate that the funding of the activities we engaged so far have been supported by training grants and by development grants, but that is just a tiny sort of contribution on the big picture of the economy, the economics of all these. And I am unable to, I don't know what it will take for some of these economies to begin to change. Sabrina was able to get some support from some of the philanthropy and foundations to actually get increased number of PPEs. But if I showed you the pictures of the isolation techniques for COVID at Sabrina's hospital, it's only 2 sheets holding the IV poles. That's how they mark where there is a COVID patient in a big room. So the limitations continue to be the greatest challenge. And again, solutions for that are something that we won't see in our time, that I'm not sure of.
Thank you. You talked a little bit about COVID-19. I'd love to hear from some of the panelists about what parts of their or aspects of their partnerships they think have made it possible to adapt during the pandemic.
It's horrible. We can't travel. Remember what Mark Twain said about traveling. You know, I put that quote in the chat for the students to see. We need to do global health from the living room of our homes, and that is never easy. Anyway, I'll let the other people talk about it.
You know, I would say, I think for global health, the most important lesson from COVID is sustainability. And maybe the second one would be sustainability. Or in Mark's, in Dr. Newton's words, the translation would be education, education, education. So I think the message to every global health advocate is through, yes, collaborate, understand issues, train, leave skills, and leave a sustainable process, project, whatever it is. Because right now with COVID, I mean, no one is able to travel. And if you had a project that just relied on you, let's say you did the first stage procedure and you'll come back in a year and et cetera, et cetera. I mean, you've destroyed the entire infrastructure, complications, et cetera, et cetera. So empowering, I'm just using my example. I have my mentor came every year for 2 months or so for many years. And so over time, of course, skills, et cetera, I did go for training. But what that means today is that he's over 80 right now, so he can retire quietly and know that his life wasn't wasted because the work that he was doing continues today. So I think sustainability should be a principal element in anything that we think about. And like I say, I think this is a great lesson with COVID. The other bit is, I think, with technology makes sustainability a lot easier because it is possible to communicate and help through with processes even without having to be in person. But it makes it foolish for me to be going down to some place in Kenya right now. From yesterday, we're on lockdown. So if I had a project that I was going out into the village somewhere and train nobody, those guys will be helpless for the next X number of months. So yeah, sustainability. Thank you.
Just one comment on that, Peter. We had to adjust some things due to COVID. Our plan was to have train Kenyans train Ethiopians, and then we have Kenyans and Ethiopians train Tanzanians, who then train Ugandans. So we've just shifted it all so that all the training's being done by East Africans for East Africans, and we at a distance kind of mentor and support. And a TOT training program that used to be in person is now virtual. And so this morning I was on a session for 3 hours, training 20 anesthesiologists in Tanzania how to be better educators. And so then they're going to educate from now on. But it has to be shifted so that we help in the ways that are appropriate. But in my mind, collecting data, doing simulation, all that stuff can be taught, and then teach people how to teach, and then have them teach and propagate it. But data collection
that's a very positive effect of COVID, isn't it?
Right. Yeah. So we are. Yeah. So Kenyans going to Tanzania is much easier than, certainly anybody from Nashville getting into Kenya or Tanzania. So, and it empowers them, and resources potentially could be available for them to have some support to do it. But that's how we shifted a little bit.
Awesome. Thank you so much, Dr. Newton. At this point, we do need to bring our panel to a close, and we would like to thank all of our panelists for taking time out of their schedules to speak with us as residents, as trainees, as just other professionals that are interested in global surgery. We spoke a lot about the sort of attitudes we need to bring to global surgery work and to creating a sustainable partnership. And hopefully we can apply that advice. Thank you again for attending the symposium, and thank you for taking the time to speak with us. And I don't know if any of the panelists would like to say any closing remarks at this point. The floor is open for you.
It would be great to share our emails if the students want to contact us. If they all had our emails, I'm fine them having mine, but that's the only thing I'd want to say.
I think that would be great if maybe we can put that into the chat. If all the panelists are comfortable with that, they can put their emails into the chat at this point.
We can also make sure that it's sent out in like the closing email for those panelists that are okay with it.
Okay, great.
Yes, thank you very much.
Thank you for the opportunity to participate, and look forward to seeing all of you and working with many of you as you become future leaders.
Thank you.
Thank you.
Goodbye now. Thank you.
Bye.